Okay, chapter 9, pre-analytical considerations. The term pre-analytical just means anything before analysis, which will be the state that the sample is in before we take it to the lab and before they run the tests on it. The pre-analytical phase encompasses all procedures before the start of laboratory testing. This phase of the testing process is responsible for most of the laboratory errors, which just means that most of the laboratory errors that happen, or the errors that happen with samples, happen in the pre-analytical phase before it even gets to the lab. So it's our responsibility until it's in the lab, and there's a lot of things that we can do to prevent pre-analytical errors. Correct organization and proper management of both personnel and procedures regarding blood specimen collection are of utmost importance. I'm going to change this, so we're going to pause and then we're going to start over because this is wrong. It's going to bug me. Utmost. There. Sorry, that would have bugged me. Okay, chapter 9, pre-analytical considerations. The term pre-analytical just means anything before analysis, which is when the phlebotomist has the control over the sample. The pre-analytical phase encompasses all the procedures before the start of the laboratory testing. This phase of the testing process is responsible for most of the laboratory errors, which just means that a lot of the laboratory errors that we see with samples, whether it be a redraw or we draw into the wrong tube, whatever it may be, whatever errors we see typically happen before the sample even reaches the lab, which means that it is more than likely the phlebotomist's fault. There are a lot of pre-analytical errors that can happen, and that's why we have procedures in place, and there are a lot of things that we can do when the sample is in our possession to make sure that these don't happen. Correct organization and proper management of both personnel and procedures regarding blood specimen collection are of utmost importance. Types of pre-analytical errors include patient ID and labeling errors, order of draw compliance errors, underfilled tubes, hemolysis, which we'll talk about, patient injury, diet, medication, exercise, anatomical position, filling the incorrect tube, improper processing, adequate or inadequate mixing, collection times, dehydration, and there's a few more that we'll get to as well, but these are the most common and what will be considered the pre-analytical errors that will cause a redraw. So before we take any samples, we have to understand that there is every single day, and this is talking about in the hospital, and we'll talk more too about like donations in a plasma center, so phlebotomy in a plasma center versus phlebotomy in a hospital. This is specifically hospital-based. So the basal state is the resting state of the body in the early morning after fasting for 8 to 12 hours. And so the basal state is after a patient has been sleeping all night, they haven't eaten anything, they've just been in a resting state. So the basal state draw happens every morning at the hospital for almost every patient, pretty much every patient, and is ideal for establishing reference ranges on inpatients, the effects of their diet, any exercise they're doing, so physical therapy, etc., on the test results are minimized. If a patient has just done physical therapy or any sort of treatment or they're on medications, those things can affect the sample, which is why we like to take a basal state basal state sample, so we can see how their resting rates compare to rates after they've gotten a treatment or done physical therapy or et cetera, et cetera. Basal state is influenced by someone's age, gender, and the conditions of their body. Maybe they have an autoimmune disease. Maybe they are more susceptible to infection. Maybe they are weak, or maybe it's an infant, a newborn who doesn't have the immune system built up yet. So there are different things that affect the basal state. We have special considerations when we're drawing from patients. These include tattoos, burns, and scars, mastectomies, edema and obesity, hematomas, hemolysis and lipemia, which we'll talk about, vascular access devices or sites, and complications with patients, patient complications. Burns, scars, and tattoos. We are trying to avoid these to the best of our ability, okay? Burns, healed burn sites with extensive scarring may have impaired circulation that could affect test results. They are very sensitive to the patient and prone to infection. Now, obviously, if someone is a burn victim and they have fresh burns, we're not going to be poking on the fresh burns. We know how burns can be uncomfortable and very painful, so we are not poking any fresh wounds or burns at all. If the burn is healed and it scars, scar tissue can be, number one, difficult to poke through. Number two, poor circulation underneath scar tissue can have an effect on the sample that we get. So we're just going to avoid burns and scars as much as we can. It may be difficult to palpate over a scar and also insert your needle through a scar. It might be very sensitive for your patient as well. So scar tissue can be sensitive. It can affect the direction your needle is going. Scar tissue is really, it's just really tough. It's really hard to poke through. And the needles, I mean, they're pretty sensitive to movement. So if there's anything that's going to block the needle, it can push it out of the way. Tattoos, fresh ink can mask infections or be more susceptible to infection. Tattoos can cover up bruising, rashes, and any other skin irritants. If you have no choice but to draw from a tattoo, try to insert your needle into a spot that doesn't contain ink or have ink. So, for example, in this picture, you can see inside the flower, there's an area where there's not so much ink, kind of the skin, where the skin doesn't have ink in it. That's kind of where you would want to poke if there's a vein there. The whole reason for this is that tattoos can cover up hematomas, which is just where we have blood leakage into the tissues. And we want to be able to spot those if it happens, because that will be an end of draw. So it can also cover up infections. And then the ink also, fresh tattoos can be more susceptible to infection, so we just want to stay away from those. Mastectomies or lymph node removals. This is very important. We are not ever performing a venipuncture on an arm adjacent to a mastectomy site. Now, here's the kicker. Sometimes women can have a double mastectomy, which means both breasts are removed, in which case they'll probably have a double restriction, which means they'll have armbands on both sides that say do not draw or do not poke or do not touch. Restricted is what it's going to say. That just tells you that you're not allowed to draw from that side. If they have a double mastectomy and restriction bands on both sides, that's a conversation that you'll have to have with the nursing staff. It could potentially lead to the nurse pulling from an IV site if there's one available, or we could then maybe take a look at feet, okay? Feet or legs, which we have to have a doctor's order for. So in this case, if we have a double mastectomy, we would be talking to the nursing staff and seeing what they would want to do, potentially drawing from the feet. If we just have one mastectomy site, then we'll have one side that's not restricted and you can just draw from that side instead. But make sure you're paying attention to the patient's wrists for restriction bands. They're pink and they'll say restricted on them. And a lot of times when a patient has a restriction band, they'll let you know, hey, this side is restricted. So patients may have no lymph flow to that arm, whichever side is removed, because the axillary lymph nodes on the mastectomy site, the mastectomy side may have been removed. This condition carries a potential risk for infection. Mastectomy and lymph removal can change the composition of the blood, and the tourniquet may injure the patient's arm. Okay, so that side is typically weaker. The lymph nodes have been removed, which means we don't have as good of lymph flow. Lymph is kind of what goes through your body and clears out impurities and stuff like that. And so we may cause injury and cause pain, and we also may get a different blood composition, which means different results for the test that we're drawing. So just keep that in mind. Keep an eye out for restriction bands, and pay attention to when your patients have mastectomies or double mastectomies. Edema. Edema can affect our blood draws. This is swelling caused by abnormal accumulation of fluid in the tissues. And this is what it looks like. This one with the foot, where there's a little divot in the foot, that's called pitting edema. That just means that there's so much fluid buildup inside the tissues that when you press on it, it maintains that shape. Sometimes you'll have edema that's caused by IV fluid leakage, or IV infiltrating the surrounding tissues, which just means that all of the IV fluid is going into the tissues, not into the veins or the vascular structure. A blood draw from an area like this can yield inaccurate results because it can be contaminated with the fluids. So really what we want to do is try to avoid any areas that have major edema, pitting edema, any kind of swelling that you can see. Blood composition can change due to swelling as well, just because we get the mixture of the tissue fluid plus the blood, and then the results just aren't correct. In situations like this, veins are harder to locate and the tissue can be very fragile. As the tissue expands with the fluid, it can be more prone to tears and lacerations and stuff like that. So we just want to be really careful when we're doing things like tying the tourniquet on, because the tourniquet can catch and tear the skin. Also, sometimes edema and the fluid buildup will be so bad that it will be seeping out of the patient's skin. So this is why, another reason why, if we kind of go backwards and talk about chapters like 1 and 2, we're always wearing gloves when we're interacting with patients. This is just one of those times where you definitely want to be wearing gloves, interacting with a patient with edema, especially if the fluid is seeping out of their skin, okay? Just keep that in mind. Always wear gloves when interacting with patients. And then if we have a patient with edema, just make sure that we are trying to select a spot that's not as swollen if there's any space. And then just being as gentle as we can with the tourniquet. And again, this would be a situation where if maybe the arms are completely swollen and the hands, and there's just no options, we can't feel any veins, and we're afraid of hurting the patient, we could potentially look lower or elsewhere, up in the shoulders and the chest, maybe down in the feet and the legs, okay? Obesity. Veins on obese patients may be difficult to see and palpate, making them a challenge to find and penetrate. Veins may be deeper than one would assume, so try rotating the wrist or the cephalic vein. We'll learn more about all the veins in the cephalic vein, but rotating the wrist as we're looking for veins like this can sometimes help veins become more prevalent. So like if, for example, if the wrist is rotated downward, sometimes this middle vein is going to be a little harder to feel. If we rotate the wrist upwards, now all of a sudden it might show itself, okay? But just in general, obese patients or heavier set patients have a lot of fat tissue, right, generally. So, and that happens all over their body. And so they can have extra tissue in the arms as well, which can make the veins appear deeper and harder to palpate. Plus you're palpating through tissue, fat tissue, instead of just skin. And so it can be kind of hard to tell where the veins are. But as you get practice palpating veins and feeling for things, you'll be able to tell. Kind of the general rule is don't really go for anything you're not super certain about. You totally can, but just remember that it's going to be a lot deeper than in someone who doesn't have all the extra fat tissue, okay? Caution must be taken not to probe the area excessively if a vein is missed. Now, on the other side of the same coin, if you think you feel something and you decide to go for it, that's great, okay? It pays to be confident a lot of the time, okay? Confidence is key. Remember that from the first slide or the second slide or the first PowerPoint. Confidence is key. It's very important to be confident. Yes, if you think you feel something, by all means, please go for it, okay? If you miss, it's very important that we don't fish or probe the area too much. So we're not just going to go like this until we hit something. We're going to make calculated movements. And this is one of my very important lessons or that I try to teach students is that we never fish and we never probe excessively in order to try to hit something and get lucky. We're always going to make 2 calculated movements. If we don't hit the vein with 2 calculated movements, then we're going to call the draw and poke again. Okay, so we're just making sure that we're not fishing for the vein if we miss. It's just not fun for the patient. It's going to make it harder for them to trust you, and it's going to knock down your confidence quite a bit. So don't do that. We do have bariatric tourniquets. Well, most clinics should have bariatric tourniquets. They're just longer tourniquets that can be used with a BP cuff or on their own to fit around the person's arm. If a person's arm is too large, one of the normal tourniquets that we have won't fit. It won't be long enough. So you can use it on its own, or you can use it alongside a BP cuff, and the BP cuff will be inflated to just below the patient's diastolic pressure. So in this situation, you would probably talk to the nurse or just look at the monitor and see what their diastolic pressure is, and then turn the cuff onto that. But a nurse should probably be present if you're doing more than just applying a tourniquet. Okay. Hematomas. Hematomas are one of the most common complications from venipuncture. It may present immediately or be delayed. Most of the time, with what we're doing, the poking that we will be doing, it's immediate. You can see it. It infiltrates so fast, and this is just fragile veins, maybe small veins. The needle is too big. There's a lot of reasons why hematomas can happen, but typically it's pretty fast. It presents itself, and you're able to see it and end the draw. Sometimes you can't tell, and the bruise will appear the next day or later in the day. It's just swelling or mass of blood outside the vessel due to injury or trauma. We are causing injury or trauma to the vein. The vein leaks blood out into the surrounding tissues and causes a bruise. If you notice this happening, release the tourniquet, remove your needle, apply firm pressure, and ice if you need to. This will stop or slow down the formation of the hematoma. Now, I've seen hematomas that aren't really that bad. I've seen hematomas that turn the whole entire arm blue, black and blue. So it does vary based on the severity of the injury. But most of the time, especially in the hands, you'll be able to see it happen immediately. Okay, it'll go, and then the blood will start pooling, and sometimes it'll cause like a bump to raise in the skin and grow. So once you see that happening, you just pull the tourniquet off, withdraw your needle, and hold pressure on that. And then to make it less painful for the patient, you can offer them an ice pack. Okay. This would also be a situation where if we do a blood draw on someone one day, and then we come back the next day and they have a bruise in the spot where we drew from. So for example, say we drew from this arm here. It has a big bruise now on the second day we go in. We're not going to draw through that bruise because we know that the vein is now more fragile because of the trauma that we caused. Okay, so the vein will be more fragile. Veins take time to heal, so we need to make sure that we are not poking through hematomas, right? We don't poke through bruises or hematomas. It's very tender for the patient, and it could still be pretty weak, so we might just cause the hematoma to get worse. Petechiae are tiny hemorrhages that appear on skin as small red or purple spots. It's kind of the same as when someone gets like a little raspberry. It's just when the blood vessels kind of burst open. Tiny hemorrhages in the blood vessels. The blood vessels kind of burst open due to too much pressure and cause a little raspberry or little red spots on the skin. Petechiae can appear from leaving the tourniquet on too long and can also cause the blood sample to be hemolyzed, which we haven't really talked about, but hemolysation is just when the red blood cells break open, which is what's happening when we're causing petechiae. So the capillaries are bursting and causing the irritation and the red spots in the skin from too much pressure from the tourniquet, and then that blood that we are now taking is hemolyzed, potentially. With this, just make sure that we're only leaving the tourniquet on for 1, maybe 2 minutes at the most. Okay, we do have specific time frames on how long we can leave the tourniquet on for, so we just want to make sure that we're paying attention to that and not leaving the tourniquet on for too long. There have been times where the tourniquet has been left on a patient all day, and these are things that you can get in trouble for. I've made that mistake before, accidentally leaving a tourniquet on a patient when I was still very new working in the hospital, and it's not good. It makes you feel really bad. It can be super dangerous for the patient, so this is really important. We need to pay attention to the tourniquets and make sure we're not forgetting that step. The tourniquet, removal of the tourniquet is probably the most commonly forgotten step that I would see with students that come through my class, okay? It's a procedure, we go through it step by step. Taking the tourniquet off is a step, and it's a step that's forgotten the most. And I have made the mistake, but you learn from it, and then you follow your steps and you move forward. So just make sure you're paying attention to the tourniquet and taking the tourniquet off so we don't cause hemolysis or petechiae. Hemolysis, since we're talking about it, is the breaking open of red blood cells and the release of hemoglobin. This release of hemoglobin turns serum or plasma red or pink. So if you notice in the photo, the first vial, okay, all the way to the left, is a nice yellow apple juice straw color, would be probably a good description for it. Nice and clear, not cloudy, okay, and not a weird color. So once we want it to be straw colored or apple juice colored. If we have any sort of hemolysis, it's going to be anywhere from orange to pink to bright red, depending on the level of hemolysis. But if it's anything other than straw colored, there's something going on with it, and it's probably not going to yield accurate results. So just keep that in mind when we're processing or transferring plasma or dealing with plasma or serum. It needs to be yellow, okay, straw colored, apple juice colored, and clear. It shouldn't be cloudy. It shouldn't have any floaties. It shouldn't have any color to it other than the straw color. Hemolyzed blood releases chemicals into the plasma and serum that adversely affect the test results, such as the potassium levels being falsely elevated. We do see potassium levels being really, really high in hemolyzed samples, even if the color hasn't changed. So sometimes it can be hemolyzed just a little bit and the potassium levels shoot up. Generally, if the potassium levels are really high and that's abnormal for the patient, it'll be a redraw anyways. But different causes for hemolysis include using needle gauges that are too small for the vein selected, so we'll get into that as we get to poking and practicing skills, but making sure that the vein we select is going to be suitable for the needle that we choose. Using the Vacutainer method or ETS on a small vein, we just want to make sure that we're using the correct needles on small veins as well. Leaving the tourniquet on for too long can cause hemolysis, we just talked about that. If we're using a syringe, pulling too quickly on the plunger, using manual pressure and pulling too fast, it can cause the blood to be forced through the needle at a higher rate of speed than the needle size will allow for. That will cause hemolysis as well. Specimen mishandled during transport. Maybe we drop it or shake it too hard, or something happens to it when we're transporting it to the lab that can cause hemolysis. We're too rough with it. And then drawing from an existing hematoma or bruise. So this is kind of another thing that can cause hemolysis in samples. If we draw through an existing hematoma or bruise, which we're not supposed to do anyways, it can potentially pull some of that leaked blood from the tissues into the sample, and that will cause hemolysis. Whoops. Okay. Lipemia can occur after someone has eaten something that is high in fat. So lipemic serum or plasma is just fat a sample that's high in cholesterol. After the blood is spun in the centrifuge, the serum or plasma portion is milky or turbid in appearance. So you can see the clear serum, which is our straw-colored clear serum. And then you can see our lipemic samples. The one on the right is a lipemic serum, and that is one that is going to be a little bit more cloudy. It's going to kind of have a dingy look to it, and that just means we have high cholesterol or someone has eaten something really fatty. Generally, in plasma centers, you'll see it a lot, and it could be milky white as well. It could also be strawberry pink, like strawberry milk. So in plasma centers, if you ever work in a plasma center, you'll see it more in the bottle as the blood is drawn and the plasma is put into the bottle. You can definitely see if someone's eaten a huge fatty burger that day. And then when you have it in the tubes like this, once we spin the sample, then you'll be able to see the milky or turbid appearance. So nice, clean, clear plasma is what we're looking for. When we have a lipemic sample, it's going to be cloudy, kind of dingy looking, or milky white. Lipemia will affect chemistry tests, causing false elevation in lab test results. So if we have a lipemic sample, it's going to give us false or weird, falsely elevated test results, and it'll be a redraw. Okay. Hemoconcentration is prolonged application of a tourniquet and can force fluids out of the veins and into the surrounding tissues. This causes the concentration of blood products to elevate, and the blood test will be inaccurate. Leaving the tourniquet on too long can cause raised potassium and some parts of the blood to elevate, okay? Specifically potassium. The other common causes of hemoconcentration include vigorous fist clenching or pumping when the patient has the tourniquet on. So just keep in mind, when we put a tourniquet on, the tourniquet's job is to constrict the arm, restrict blood flow, and raise the pressure, okay? It's doing its job. When we put the tourniquet on, we don't need any assistance, any sort of pumping like this. We don't need anything like that. So sometimes you'll see like nurses and doctors and phlebotomists even say, pump your fist for me, okay? In plasma centers, that's okay. In plasma centers, it's okay to do that, okay? Because this can help with the full draw of the red blood cells before it centrifuges the plasma out. In the hospital, once you've applied the tourniquet, we don't want to ask the patient to pump their fist, okay? The tourniquet's going to do that for them. The tourniquet's going to do its job. And then another common cause for hemoconcentration is dehydration. If a patient is dehydrated, sometimes it can be harder to locate and perform our venipuncture. Sometimes you don't get a very good sample. So this is kind of a visual representation of hemoconcentration. As we go through this, you can see that we're using hemoglobin and hematocrit as a guide to hydration status. So when hemoconcentration occurs here on the right-hand side, this just means we have a greater amount of red blood cells versus water, so hydration in the bloodstream, okay? So when we have a greater amount of red blood cells, we have less plasma, so our concentration of red blood cells is higher. As we go down, we kind of have a normal range, and as we go up in hydration, okay, we have less red blood cells, okay? Our red blood cells can become diluted. And so this is kind of a visual representation of the difference between a volume deficit or dehydration and a volume excess, which is overhydration. So as we become more hydrated, the volume of our red blood cells goes down and levels out. And as we become less hydrated, it goes back down. And we get a difference in how much plasma we yield when we spin a sample. Okay, as we're moving forward, vascular access devices are something that we as phlebotomists are out of scope to touch. So we just don't touch them. The short of it is we leave them alone, okay? And we'll talk about the different vascular access devices. And vascular access devices are things like IVs, PICC lines, things that the nurses or doctors put in place to have access to the vascular system. IV lines are going to be the big and most popular one that we see. So an IV is a catheter inserted into a vein to administer fluids. Drawing blood from a patient's arm in which there is IV fluid running is not recommended and should be avoided. If you go into a patient's room and they have an IV placed with fluid running into it, we are trying to avoid that arm if at all possible. So we'll check the opposite arm first. If we can't find anything on the arm without the IV, we can draw from the IV site as long, or not the IV site, but the IV arm, as long as we poke somewhere below the IV insertion site. So in this photo, you can kind of see the hand down below. The IV insertion site is up a little bit higher, anywhere from here down, you could potentially find a vein and poke that arm, okay? We're not drawing anywhere above the IV site or next to the IV site. We're just leaving it alone completely, okay? So the tourniquet and all of the blood draw procedure needs to happen below the IV site. If there's no alternative and an arm with an IV line must be used, always draw away from and below the IV insertion site. Now, there is a kind of caveat to this. If there is nothing below and away from the IV site, we can ask the nurse if they're okay with us pausing the IV fluid. If we pause the IV fluid, we have to give it 2 minutes to circulate, okay, so that we can get a fresh blood sample because the IV fluid was just running in that vein, right? But we can then poke above the IV site. So if we pause the IV fluid, allow 2 minutes for circulation, and then we can poke above the IV site. Otherwise, it's down, away from or below the IV site, or on the opposite arm that doesn't have an IV. PICC lines, or peripherally inserted central catheters, are used for IV access on a long-term basis. They are threaded along the vein up to the superior vena cava of the heart and allow the maximum number of drugs or fluids to be diluted immediately. Only an RN can or will draw from the PICC line. Now, that is true, but RNs can only draw from vascular access devices at all, okay? So we are not drawing or pulling from IV sites. Sometimes the nurses will offer that to us. Otherwise, we are always poking peripherally, okay? That's our job. Sometimes the nurses will pull from these devices, but a lot of times the reason why they have a PICC line or a device like this is because they couldn't get IV access and this was their next best thing, which means it was probably really hard to place and they probably aren't going to want to risk ruining the integrity of the PICC line or the IV, okay? So just keep that in mind. Nurses will not always draw from these for us, but sometimes they will. So we'll just always leave these alone. Arteriovenous shunts, fistulas, or grafts. An arteriovenous shunt is a permanent surgical connection of an artery and a vein that bypasses the capillaries and forces arterial blood direction into a vein. A fistula is a dialysis shunt created by direct permanent fusion of the artery and vein located above the wrist. Now, these are seen in patients who receive dialysis treatment. Okay, these are very, very important. They receive dialysis treatment through this, and so therefore we cannot touch it because it is a dialysis patient's lifeline. We should never be applying a tourniquet or performing a venipuncture on an arm that has a fistula or a shunt. You can see it pretty much as soon as you walk in the room when you're looking at the patient's arms. Typically, it'll look like a huge, bulging, like unnaturally large vein, almost like a big worm or like a snake under the skin. It's very bizarre, but it is their lifeline. It's very important to their dialysis treatments, and so we just leave them alone. If we can, use the opposite arm. Don't ever touch that arm. Don't ever put a tourniquet on the arm because we can cause trauma and damage to it, which can affect their treatment. If they have it on both arms, this again would be a situation where we would talk to the nurse and see what the options are and see what the nurse recommends or what the doctor wants, and potentially even drawing from lower in the body, feet or legs, or we can look up in the shoulders and the chest, okay? Central vascular access devices, or CVADs, they're also known as indwelling lines, consist of tubing inserted into a main vein or artery. They are used for administering fluids and medications, monitoring pressures, and drawing blood. So they have a port that sits under the skin, and then from that port, the line travels down the superior vena cava and into the cavo-atrial junction. So it goes even farther than the PICC line goes. It goes into the superior vena cava and down into the heart. Central venous catheters are inserted into a large vein, advanced into superior vena cava. So a central catheter or central line is going to be inserted up here, kind of in the neck area, so subclavian, here. And then it'll go down into the superior vena cava And again, it's just used for sometimes blood draws, but immediate dilution of anything that they're giving this patient. An implanted port is a small chamber attached to an indwelling line. It is surgically implanted under the skin in the upper chest or arm. And again, from the port, okay, we have the line that goes into the superior vena cava, and again, is for administering fluids that can be immediately diluted or drawing blood. Peripherally inserted central catheters are the same thing as a central catheter that's inserted subclavian on the subclavian artery. But it is inserted in the veins of the extremities and then threaded all the way up the veins into the central veins. So it will be one that's down in the arm, kind of like an IV, but it's threaded through the veins and up into the body. Moving into patient complications. Some patients can have allergies to the equipment and supplies. The most common one is going to be tape. Okay? So when a patient has an adhesive allergy, usually they'll let you know. Sometimes it's to Band-Aids, sometimes it's to paper tape. Most of the time it's to the plastic medical tape that can cause irritation on the skin and rash on some patients. If someone doesn't know, then obviously you wouldn't know if they have an adhesive allergy. So when you're poking a patient, if they already have tape over a venipuncture site and it's causing irritation, what we're going to do is remove, or if someone tells you they have an adhesive allergy, what we're going to do is instead of putting tape on their arm, we're going to place gauze over the site and just have the patient hold it until it stops bleeding. This says 15 minutes. Sometimes patients stop bleeding a lot faster than that. So what you need to do is stay in the room and just check it until it stops bleeding, and then you're good to go. Or you can have a patient apply pressure for 5 minutes instead of putting a bandage on. On the other side of that, if someone doesn't know that they have an adhesive allergy and you or someone else has placed tape on them and you notice that it's giving them a reaction or they're getting some irritation, redness, swelling, any rash, that sort of thing, we are removing the adhesive from their skin, giving it a clean, and then leaving it untouched so that it can heal on its own. The nurses and doctors can put like ointments and stuff on it if they feel necessary, but we don't do any of that. We are just simply removing the adhesive and cleaning the skin off, whether it be with soap and water or just giving it a wipe with an alcohol swab really quick, as long as it's not too painful for the patient. Now, that being said, some patients also have allergies to the antiseptics that we use, which is the alcohol swabs and the iodine swabs. If they have an allergy specifically to alcohol, we're not going to use an alcohol prep pad on them. We're going to use an iodine prep pad or an iodine swab stick. If they have an allergy to iodine, then we'll probably use a ChloraPrep, which is chlorhexidine gluconate, and povidone iodine. So those are our two choices, but chlorhexidine gluconate is our second choice. And that's just an iodine alcohol-free swab that we can use. The way that I kind of bring this up to patients is when I go into a room, I'll kind of start out with my, hi, I'm Samantha here from the lab, here to take a blood draw, is that okay? Okay, I introduce myself, let them know what I'm doing, ask them their consent, they say yes, and then as I'm getting my things ready, I'll say, are you allergic to tape? And they'll say yes or no. And then you can decide what you're going to do from there. And then I can also ask them, do you have allergies to alcohol prep pads or anything like that? You can also use soap and water. So you could get like a paper towel, put some water on it, put some soap on it, and use that to clean the area as well if a patient is allergic to alcohol, iodine, and the ingredients of ChloraPrep. Excessive bleeding can be a patient complication. Patients usually stop bleeding in 2 to 6 minutes. Some medications may prolong the bleeding time. Blood thinners, arthritis medications, and aspirins are good examples of this. Physicians must be notified if the bleeding does not stop, which is why it's really important for us as phlebotomists. When we get done poking someone, we're staying in the room until we can make sure that the blood's not seeping out, right? So generally, we would poke the patient. Then when our blood draw was finished, we would remove the needle, place a gauze, Have the patient hold it as we get our things ready to leave, label our tubes and things like that. And then we would come over and put a piece of tape or a bandage around that gauze. But before we do that, before I left the room, I would always lift up the gauze and make sure it wasn't actively bleeding everywhere. And then I would put the tape on and say, you can take that off in about 15 minutes. So just make sure that the bleeding is slowing or stopping before you leave the room. Okay, this is really important because say you do a blood draw, you don't wait until the bleeding has stopped. The patient is on blood thinners and they're just bleeding a little bit excessively. The nurse comes in, they're bleeding everywhere. They're going to wonder what just happened, and you are responsible for that and not making sure that the patient stopped bleeding before you left. If the bleeding does not stop, they do have to notify the physician, and these are things that you could get in trouble for. So just keep that in mind. It could be considered negligence or something else. On the floor in the hospital, we never use Coban. In the plasma centers, we use Coban, okay? But we're never applying a pressure bandage instead of maintaining pressure until the bleeding has stopped. We really, really want to make sure the bleeding has completely stopped before we put a pressure bandage on at all. And in outpatients, which is where the patients come to the lab to have a blood draw done and then they go home, in outpatient, we are not dismissing outpatients or leaving the patients until the bleeding has stopped. We just want to make sure that we stay with the patient until we can pull the gauze up, make sure that they're not actively bleeding, then we can put the tape on and say, okay, you're good to go, have a good day. Okay. Syncope or fainting is something that you might see quite a bit as a phlebotomist. It's just kind of one of those things. People are generally terrified of needles, right? Some people don't care, some people can watch, some people are used to it from getting poked all the time, but sometimes you'll get the people that are deathly afraid of needles, are so terrified, and it causes them to have a reaction. So things to kind of pay attention to, and this is one of the reasons why I always check in with my patient as we're going through the blood draw. After the poke, I will say, how are you feeling? They'll say, good. I'll say, okay, great, we're almost done, just hang in there. After I pull the needle and place the gauze, I ask them how they're feeling. And then before I let them go, I ask them how they're feeling again. So check in with your patient. Patient check-ins are important. It's something that we'll also practice when we're doing our skills. So also pay attention to your patient's face, okay? They might, and you'll be able to feel through your gloves as well as you're touching them. Their skin might start to get cool and clammy. They might start sweating excessively. They might turn colors. They might totally blanch and lose all the color in their face. Or they might turn green, okay? It kind of just depends. But pay attention to the feeling of your patient's skin. If they're getting cold, cool, clammy, sweating excessively, they start turning white. If a patient expresses concerns about fainting before your draw, place him or her in a reclining position. If a patient has had experience with a blood draw where they've fainted before, they're probably going to tell you that. So just lay them down. Lay them down and it'll go a lot smoother for both of you. If your patient feels faint during the procedure, immediately remove your tourniquet and needle, sharps your needle, and do the following. Place a cold pack or wet towel on the inside of the wrist, patient's chest, or back of the neck. If possible, place the patient in a reclining or laying position and stay with them at least 15 minutes until they have recovered. The patient should not drive for at least 30 minutes after recovering. A glass of juice may be helpful. And file an incident report listing the facts and follow up to the incident. So, if someone expresses that they're not feeling good and they might pass out, we're immediately ending the draw, okay? Then we can offer them a snack or an apple juice or a cup of water. I would typically grab an ice pack and place it on their chest or on the back of their neck. That will help to cool them down, because what's going to happen when they start to feel faint is their body temp is going to rise and they're going to get really hot. As we cool the body down, that feeling of syncope will go away. If they end up fainting, what we want to try to do is remove the needle, okay, because they're going to tense up. Remove the needle, cover the spot, and lower them to the ground to the best of your ability. We're going to place them on their back, laying on their back, and just elevate their feet, okay? Then we're going to just, as they wake up, say, you're okay. Make sure they know they're in a safe space. Make sure they know that you have them and that everything's fine, and just have them not get up too fast, okay? Have them lay down until they're feeling comfortable enough to get up, and then we can slowly have them sit up to start, give them water, juice, or a snack, or a combination of the three, and then have them wait until they feel good enough to stand up, and just take it in stages, okay? From laying down with feet elevated to sitting up with a snack or juice or water, to standing, making sure that they feel good enough to stand up, and then to walking, and then they can leave. Okay, we're just not rushing things. We don't want things to go so fast. We want to make sure the patient's okay and they're not going to faint again as soon as they get out the door. Okay. Seizures are something that are a little bit less common. You just never know if someone has a seizure condition. It is possible that someone could have a seizure in your chair. If that happens, again, we are just discontinuing the draw immediately. So pulling the tourniquet, pulling the needle, covering the site. Call for help. Ease the patient to the floor and turn them on their side to keep their airways clear. Put something soft under their head if you can. If you can't, just hold their head so they're not like hitting it on the floor or anything else around them. Loosen anything that could obstruct their airway, a tie or a top collar button. Try to protect the patient from inflicting any injuries on themselves, which just means hitting their body parts on surrounding objects. And then time the seizure and notify the appropriate personnel. So call for help and time the seizure. That way, when help arrives, you can tell them when it started, when it ended, so on and so forth. This is the most important one. Do not put anything inside the patient's mouth. It's a stigma to do this. We're not putting anything inside of someone's mouth who's having a seizure at all. Okay, ever. We're not putting a belt. We're not putting anything in there so they can bite. So what's going to happen is their jaw is going to clench as they're having a seizure, and they have the potential to bite you if you try to open their mouth to put something in it, including your fingers. So just keep your fingers and all other things away from their mouth and let the seizure run its course, okay? Just protect their head and their body from hitting on things, and it'll be fine. Moving into procedural error risks. Infection is one that we're worried about, especially in the hospital, and we want to just make sure that we're taking care of the patients and protecting them from infection by doing the following. Following all proper site preparation protocol, which just means that we're cleaning the site, using aseptic technique, using the proper antiseptics. We're not taping open bandages ahead of time. Oh, sorry, we're not, what did I just say? We're not opening tape or bandages ahead of time. We want to make sure that everything we have maintains its sterility. So anything that's in a single-use package, we're keeping all of that packaged until we're ready for the draw, which means I've just entered the patient's room, introduced myself. Now I'm collecting my supplies and I can open everything that's one-time use, open all my packaging. So that way it's got the highest level of sterility. Do not touch the needle insertion site after sterilizing it. Okay, after we clean the venipuncture area, we are not touching it. We're not letting the patient touch it. If anything touches it, the tourniquet, my hands, the patient's hands, if anything touches it at all on accident or on purpose, it needs to be re-cleaned. It's very important. Please minimize the time between needle cap removal and venipuncture. Removing the cap of the needle should be the last thing you're doing before you're poking the patient. Okay, we're not uncapping the needle, holding it over here, finding the vein, and then poking. We are finding the vein, cleaning, letting it dry, pulling traction, uncapping the needle, and poking, okay? So it should be uncapping the needle, straight into the poke, no waiting. And then just remind your patient to keep the bandage on for at least 15 minutes, 15 to 20, I like to tell them. Some patients leave it on all day, some patients leave it on longer than that, some patients try to take it off sooner. 15 to 20 minutes is what we like to see so the bleeding can stop and it can have time to coagulate and kind of cover itself up, right? So as the scab or the coagulation forms, it's going to plug the hole that we just made into the body, okay? Which keeps infection and things out. So just remind them to keep it on for 15 to 20 minutes and then they can take it off. We can cause nerve injury, okay? So they can be caused by improper site or vein selection, inserting the needle too deeply or too quickly, excessive lateral redirection of the needle, or blind probing or fishing. If initial vein entry is unsuccessful, we must use slight forward or backward redirection. And just remember that we're not fishing. We are using 2 calculated movements, backwards and forwards, not side to side like this, okay? We're not moving it around like this. It's backwards, palpation, pull traction, and redirect in the direction that we can feel the vein in. If you can't get it after 2 calculated movements, we are removing the needle and trying for a different venipuncture site. If we strike a nerve, we can cause injuries that can last a week, a month, 1 day, a few hours, years. It just depends on the severity of the nerve injury. And this is why it's really important that we pay attention to where we're poking, okay, and how we are troubleshooting missed venipuncture. We've talked about hematoma formation. If a hematoma starts to form, discontinue your draw and hold pressure over the site for 2 minutes. Offer your patient an ice pack. Okay. Iatrogenic anemia is anemia brought about by blood loss from blood draws. Okay. We kind of talked about a little bit, I don't know if you would remember, but in the first or second PowerPoints, we talked a little bit, a tiny bit, I think I mentioned, about how there is a certain amount, so a maximum amount that we can draw from a patient each day depending on their weight. We can cause anemia in a patient, which is brought about by blood loss from drawing too much blood. Life can be threatened if more than 10% of the blood volume is removed at once. So what we're doing is collecting only the minimum specimen volumes that are required for each blood draw, especially in infants and children. Okay, adults, we have a lot of blood to give. Children and infants don't. So just make sure that you're protecting yourself and protecting your patient and paying attention to the amount of blood that you're drawing from infants and children, because we don't want to cause harm to them and cause anemia. Inadvertent arterial puncture. Sometimes we can accidentally puncture an artery, which is fine, okay? There are just steps that we need to take if we do this. So what will happen when you puncture an artery is you'll see, instead of like a dark red cherry blood that's flowing nice and smoothly into the tube, it will be a bright red blood that will be spurting with the pulse into the tube instead of a nice steady flow. This is okay. If you puncture a vein, an artery, don't panic. All you need to do is release the tourniquet, pull your needle out, but we're holding pressure for extra time just because arteries are pressurized, right? They have a pulse, and so there is a potential that they could bleed longer. We need to hold pressure on arteries if we poke them on accident longer than veins, and just make sure that the bleeding has stopped. These are going to be a little bit confusing until you come for skills and until you're able to actually poke and troubleshoot venipuncture. These are just some examples of what missed venipuncture looks like. So, box A is a correct needle position where blood can flow freely into the needle. This is what we want the venipuncture to look like. This is a successful venipuncture. This is what we're aiming for. Blood B is the needle is not inserted far enough into the body, so the needle does not even enter the vein at all. Okay, this can happen sometimes if we poke a little bit too shallow. We just need to advance a little bit further. E is a needle bevel partially through the vein, causes blood leakage into the tissue. And then there's an example of a nerve, that's the yellow line that you see. But it is possible that we can go too far, okay? Which means that we poke into the vein, past where we are supposed to stop, and go through the other side, okay? In the top, out the bottom. This can sometimes, and this is where we see a lot of our hematoma stuff, okay? If we puncture all the way through the vein, sometimes we'll get blood leakage, and that's hematoma. If we puncture through the vein all the way, but we don't have blood leakage, there's no hematoma, this is just poking through, and you can back the needle out and obtain blood flow still. You also still might obtain a hematoma as well, because as you pull the needle back through, then there's an open hole in the bottom of the vein now, and blood can leak through that as well. So, kind of just depends on the situation that we find ourselves in. This one is a needle bevel partially out of the skin. So as you can see in the top one that says C, the tip of the bevel, the top part of the bevel, is outside of the skin, which can cause a loss of our seal, our vacuum seal, okay? You'll kind of hear a little, and that's air being sucked into the vacuum tube. If we lose our seal, the needle is now not good anymore, okay? Our tube is no good. You can try to get a new tube, but once the seal is lost, we kind of just have to get new tubes and start over. The needle bevel partially into the vein, which causes blood leakage into the tissue. Now this is kind of the opposite side of the hematoma that we already saw, where we poked all the way through the vein. This is just where we've partially poked into a vein, but we're not quite there, so there's leakage coming out just of the top of the bevel here. G is the needle bevel up against the vein wall, can prevent blood flow. This will happen if the needle is too big for the vein you've selected. The pressure will be too great, the vein will suction over the needle, and the needle will be blocked by the vein wall and blood won't be able to flow into it. That's K. So G is just where the needle bevel is against the upper vein wall. Sometimes you can hit the vein wall and prevent blood flow. And then sometimes you'll hit the vein wall and the needle is too big and can cause the vein to collapse. And then the vein suctions around the needle and will reduce our blood flow or cause no blood flow. And then this is just a missed vein, needle beside the vein. Sometimes veins can move. Even if it feels like it's pretty solid, it's not going to go anywhere. If you don't pull traction hard enough or hold your vein in place well enough, the vein can move out of the way. Sometimes veins have thicker walls than we think, which means the needle can just hit it and bounce right off. It deflects it, depending on the size of the needle. So just be aware that even if the vein looks really good, sometimes it can just deflect your needle or you can miss, okay? No blood helpful hints. If we have a collapsed vein, this just means the vein walls draw together temporarily, shutting off blood flow. It's caused by the vacuum of the tube or the plunger pressure being too strong for the vein. So the vein is just too small. The tourniquet is too tight or too close to the venipuncture site, which can cause the vessels to close off. Or the tourniquet is removed during the draw. If we remove the draw too soon, especially with elderly patients, it can cause the pressure in the vein to go down, which will cause collapse in the vein. The tube vacuum, we can lose our vacuum seal due to bevel backing partially out of the skin, or loss of vacuum due to damage or expiration of the tube. It's very important that we select tubes that are in date. So we're always checking the expiration dates on our equipment, and that includes tubes. Make sure we're using tubes that aren't gonna give us issues. Maintain a solid base and keep the structure of your hands strong and firm during venipuncture. This is important. If you don't have a solid base, you have the potential to back the needle in and out as you're doing the venipuncture. This can cause the bevel to come out or the needle in its entirety to come out of the skin, which will end our venipuncture or lose our vacuum seal. So just maintain a strong, firm base as we're poking, and you shouldn't see any issues with backing in and out. This is something that requires practice. You're not going to be perfect at it when you very first start poking, so just keep in mind that a solid base is going to eliminate a lot of the problems that you see here.